Now, my interest in cholesterol and low carb started with my own results in 1989, and my results were diabolical, really high trigs and HDLs well below 1. It was diabolical, but for some reason, maybe because I was on a low-fat diet, I thought that I was okay. Around that time, I was in charge of the lipid lab at St Vincent's Hospital, and we were very interested in sort of some new ideas about predicting types of LDL. So the phenotype, small dense LDL. So the phenotype A, which was the healthy LDL, occurred when your triglycerides were below 1.5. And if your triglycerides were over 1.5, you had this other phenotype of small dense LDL, a much more harmful LDL. And so we actually did experiments on various patients, renal patients, patients with pituitary disease, and we found that correlation. Wherever there was cardiovascular disease, there was small dense LDL. So, I quickly started rethinking in the early 90s. It took me 10 years to sort of try to master this whole area of obesity because of the complexity of the discovery of fat hormones and everything. So I published a few papers. Interestingly, in this paper, where I tried to link all of these things, I didn't really consider that there was a link between dyslipidemia and fatty liver, abnormal blood lipids and a fatty liver. And there is, and I'll sort of describe that soon. But for me, there was a big change in 2008 when this guy called Robert Lustig came to Australia to lecture in Adelaide. And it was like the whole audience of scientists was like shocked, and they didn't touch any of the carbs of the morning tea. And then the year after, he published his Bit of Truth video, which went viral, and really was a lay interpretation of what he told us at the conference before. And in Australia, David Gillespie also sort of got involved in that and sort of pointed out the harms of sugar and fructose as part of that processed food issue. So, with that understanding, I got to lecture in various places around the world, and I started doing these YouTubes. I still can't get my head around this. I really did think YouTube was like cat videos and things. So the fact that hundreds of thousands of people might sit down and listen to science for half an hour is really just, anyway. One of the persons that listened to that was Damon Gammo, and he said, "God, could you come on board for the movie?" And that was really tough for a pathologist who hides in a lab to think you're going to be on the big screen. But the message was worth getting out. And this was the moment in the movie where we looked at his results and we realised on his low-fat diet, all of the carbs that he was taking caused him to have a fatty liver. He wasn't eating fat, but he ended up with a fatty liver because the sugar was being converted to fat. And, yeah, the extra funding he got, he managed. I didn't agree to that. It wasn't in my contract. Anyway, and these are the results back then. You can see down there that the ALT level, which was normal because he was sort of a low-carb person before he went into this diet, all of his results were pristine. And then within two or 3 weeks, he developed a fatty liver, which is the first time I'd ever seen that described. So not only can fatty liver be reversed in a week or two, it can be generated in a week or two. And this was me with the movie. I was actually worried about all the interviews after the movie, and when people asked me what would I be eating, and I thought, I better eat something healthy. So I went to a low-carb diet, and all those high trigs disappeared. My HDL went from 1.0 to 1.7, and it was like magical. It transformed my life, and I'm very grateful for the community for that. A speaker that's come to Australia before and to New Zealand is Richard Johnson, and I really take a scientific view of diets. And he's sort of an evolutionary biologist, so he's learned from animals the whole issue about how diet impacts physiology, studying hummingbirds and bears and so on. But he's transferred that through to humans. And in Australia, there's another guy called David Raubenheimer. He's not a particular low-carb advocate, but he does understand the impacts of diet on the organism. And this is his geometry of nutrition, which I use as a way of understanding the balance of macronutrients. And the idea here is if you change the fat content of a diet or the carb content of the diet, it has an impact on you, whether you gain weight, whether you develop a fatty liver. And this is the summary of about 16 human studies looking at how the different macronutrient contents change your weight and your risk of fatty liver. And so if we look at increasing protein, as you increase protein, you're more likely to lose weight. If you've got a low protein diet, you're more likely to gain weight and develop a fatty liver in these studies. If you're increasing fat, so as you increase fat, well, fat on its own doesn't really cause a weight gain or a weight loss. It's more related to carbs and protein. So high fat on its own doesn't really do anything. It's the other nutrients like carbs and protein which really influence this physiology and balance. And then carbs, they're on the diagonal, so increasing amount of carbs does move you from that weight loss into that weight gain, but on the diagonal, if you like. So high carb diets are more likely to be weight gain and fatty liver. And low carb diets are more likely to be in the blue zone, the cool zone of weight loss and no fatty liver. Now, at the risk of elevating meta-analysis to a gold standard, generally low carbs in a meta-analysis do exactly what Raubenheimer describes. Low carb diets lead to weight loss. And low carb diets also, high carb diet, this is to do with a carbohydrate dependent diet. So a high carb diet increases weight, but it decreases cholesterol and decreases LDL. And that's why people love it, because we're so focused on cholesterol and LDL. People say, you need a carbohydrate diet because it's going to lower your cholesterol and LDL. But if you look a bit further, it also lowers your HDL, which is the good cholesterol. Did you really want to lower the good cholesterol, the so-called good cholesterol? And the low-carb diet increases your triglycerides and worsens this ratio called the total cholesterol HDL ratio, which is the more powerful predictor amongst all of those measures there. High-carb diets worsens the total cholesterol HDL, so it's a higher total cholesterol HDL ratio. Whereas a high saturated fat diet, yes, it increases cholesterol and it increases LDL. I'll go through the mechanism soon. It increases HDL, and the net effect is an improvement in that highly predictive ratio, the total cholesterol HDL ratio. And people are starting to take a bit more notice about these other parameters because they're more predictive than the total cholesterol and the HDL. They've been stuck on the top line. And I have to apologise because labs still put cholesterol and LDL towards the top line, and so people would naturally expect they must be the most important thing. But when I'm speaking to doctors and patients, I tell them to look at the bottom line, because the bottom line is the bottom line. It's where the information is. Now, fructose intake, now it's particularly fructose that causes the rise in triglycerides and the worsening of HDL. So as you increase fructose intake, your plasma triglycerides are higher. And notice here that we're not talking about really high triglycerides. A high fructose diet, the average triglyceride level is like 1.5. Now, most doctors in Australia would think a triglyceride of 1.5, that's perfectly okay. Well, it's not. And that high triglycerides not only make those ratios worse, but high triglycerides are the thing that predicts whether you're going to have a fatty liver. It's not surprising. If you've got fat in your blood, you're likely to have lots of fat in your liver. It's the most predictive part of the whole thing. And I look at triglycerides even more than I do the liver function tests. If the triglycerides are over 1.5, a bit like small dense LDL, if your triglycerides are over 1.5, I'm almost certain you've got a fatty liver regardless of what your ALT says. I guarantee your ALT will be above 20, and it may be above 30 or 40, but it will be above average. So these slides, which I show in almost all my talks, are to do with rats eating fructose and nothing else but sugar. And what happens to them is they start developing fat because fructose is converted to fat. That's the whole problem. Glucose doesn't have to be converted to fat, but fructose, in the presence of glucose and insulin, has to be converted to fat. And so fructose is equivalent to a fatty liver, and fructose is equivalent to triglycerides in your blood. It's paradoxical that a low-fat diet high in sugar is what increases the fat in the body and the blood. Now, and that was in animals, and when you look at humans and say, what is it that predicts fatty liver more than anything? It's foods containing fructose, soft drinks and biscuits and cakes and so on. But that's not where it stops, because when you have a fatty liver, this is a sort of a fatty acid analysis of the liver. When you have a fatty liver, you will also have fatty muscle, and you will also have a fatty heart and a fatty brain and a fatty kidney everywhere. This fat that doesn't go anywhere accumulates in the body, accumulates in every tissue. And it'll be interesting to hear some talks tomorrow about the impact on all of those tissues, the relationship of that high content of fat on the insulin sensitivity of muscle. So fatty liver, whilst we use it as a general term, means fat messing up metabolism in all the cells of the body. And so this idea that, now we're not entirely sure where is it that insulin resistance occurs in all tissues. And it's all somehow related to these changes in fat metabolism or energy metabolism. Now, I'm going to talk a bit more about the cholesterol measurements, LDL and so on. So the liver, loaded with fructose, has to export fat, and exports it in its usual truck for fat, triglyceride, which is the VLDL. So this is the triglyceride transport system of the body. It's the system that people on high-fat diets also use to transport fat to the cells. But in a patient on a high-carb diet, this fat is being exported, and it's being taken. Ideally, it should be taken up by muscle and burned. But unfortunately, the muscle's not, in a person on a high-carb diet, the muscle's not interested in taking up the fat because it's got all this sugar around, glucose. So what does it need the fat for? So people on a high-carb diet are carb-adapted, and 80% of the energy burnt by their muscles is carbs. They're not interested in burning fat. So this triglyceride load, whilst it should be decreasing as it gives up, it takes a long time to do that. So the dwell time of VLDL moving through to LDL is delayed, and that's why they have high triglycerides, because it just doesn't clear. And not only that, but rather than going back to the liver, it's somehow changed in the process. It's interesting, I didn't put this paper in, but the most glycated lipoprotein in the blood is VLDL. So VLDL is actually changed in diabetics because it's more glycated than anyone else. And it's glycated because it hangs around so long, it just accumulates glucose. And so this LDL hangs around in the blood and it gets smaller and smaller, mainly through this action of this enzyme called cholesterol ester transport protein. So the LDL gets smaller and smaller, and by the time it gets this small, the liver's not going to have anything to do with it. It's junk LDL, and the only place it can go is into the macrophages. And if those macrophages, the disposal system of your body, is in the blood vessel wall, Well, that's a disaster because they're engorging themselves on LDL, and that's what fatty streaks and atheroma are. Now, we're not entirely sure about one last thing. Is it the fact that it's small? Is it the fact that it's been in the blood for a long time and been glycated and oxidised? What is the most important factor that makes small dense LDL so atherogenic? It's probably everything, but we're not sure which ones, whether any of those components are more important than others. So we sort of just say that it's a mixture of oxidised LDL, glycated LDL and small dense LDL, because they're all measures of LDL which has been floating around for so long because the body hasn't been interested in fat metabolism. And these are some decay curves of what the difference in the disappearance of LDL from the blood in diabetes. So if you've got, severe diabetes, it takes even longer to disappear. If you're healthy, it disappears quickly. If you've got inherited hypercholesterolemia, where you've got no receptors, well, guess what? The LDL hangs around a long time in the blood and it becomes small and dense. So even in familial hypercholesterolemia, it's a particular disease, it's a high LDL disease, but it's a small, dense LDL disease because the LDL's been hanging around in the blood so long, it's small and dense. That's what makes it so atherogenic. And the last one was CKD in kidney disease. Largely because they're insulin resistant, it takes a long time to clear LDL. They have small dense LDL, and that's what causes cardiovascular disease, so high rate in renal patients. Now, I mentioned this CETP protein, and there was in a way, CETP was helping to cause small dense LDL by allowing that exchange of triglycerides with LDL and HDL and so on. So people have developed these CETP inhibitors to try to increase HDL so they didn't disappear. They were focused on increasing HDL. And the studies have been really disappointing because even though they may have increased HDL, they haven't really improved cardiovascular outcomes. And in fact, sometimes they've worsened things. And so in a way, this didn't fit the theory because I'm telling you that it is an important player. Recently, people have described that the way that CETP does the transfer is two different mechanisms. One is sort of a diffusion and one's a sort of a flip-flop mechanism. And the drugs have different effects on the different mechanisms. And so even with the CETP inhibitors, they vary in whether they increase HDL or they impact LDL, like making it less small and dense, or both. And so now there's a new class of CETP inhibitors where they're trying to differentiate the impact on HDL and the impact of LDL. Now, I'm not here to promote CETP inhibitors. I'm just saying that one of the best things I like about drug studies is they tell us so much about physiology and help us understand what health is all about. So what I've just told you about fatty liver and small dense LDL and oxidation, that's in a review in Atherosclerosis 2024. So it is taken as gospel by cardiologists and so on, this whole idea of fat and small dense LDL and oxidised LDL being the cause. That's how the modern cardiologist thinks. And in these older studies, the RX studies, when you look at the different types of LDL, if you've got the large buoyant LDL, the stuff that's made quickly, returns to the liver quickly, there's no difference in cardiovascular risk, no matter what your LDL level is. But if you've got that small dense LDL, it's a huge difference in what your cardiovascular risk is. So I often say anybody who's thinking cholesterol is 30 years out of date. Anyone who's thinking they're really clever by LDL, which is bad cholesterol, is only 20 years out of date. Anybody who's understanding small dense LDL, well, is at least within 10 years of date. And anybody who's questioning what is it about small dense LDL that's so atherogenic is up to date. And now we can measure small LDL. There are labs in Australia that can measure it. We do this by electrophoresis, and you can separate it out. And I think some of you would have seen these tests. So the top one has got LDL 1 and 2, which are large and buoyant. The bottom one's got LDL 1, 2, 3 and 4. The higher the number, the more small and dense it is. And that's the bad pattern. And there's other things in that. You can see that their VLDL is high because that's where the triglycerides are. And you can also see that their HDL is low. So the whole pattern is not just one thing that tells you that there's insulin resistance. It's the whole pattern that's telling you what's happening for this patient. And as I said, if your triglycerides are over 1.5, you can spend $120 on that test, but I'm telling you there's going to be small dense LDL. And the only way to be really confident that you haven't got small dense L is a triglyceride below 1, which is what most people on a true low-carb diet, less than 50 grams, achieve, triglycerides less than 1. That's sort of the healthy or the therapeutic level. Now, what is it, rather than paying $120, I'm sort of saying, well, triglycerides predict it. Is triglycerides the best predictor of small dense LDL? I looked at this, and triglycerides had a Spearman correlation coefficient with the finding of small dense LDL of 0.45, which is pretty average. It's almost like tossing a coin. It's not that great. LDL is worse. Measuring LDL doesn't tell you whether there's small dense LDL. Measuring cholesterol certainly doesn't tell you whether there's small dense LDL. Measuring HDL doesn't tell you that. Interestingly, measuring HDL doesn't tell you that. Come back to that. Measuring non-HDL, which is total cholesterol minus HDL, is better than triglycerides at predicting small dense LDL. Measuring the LDL to HDL ratio is better. And for me, the best ratio at predicting the small dense LDL was total cholesterol HDL ratio. Now, I haven't got trig to HDL ratio there, and I might repeat this study with that, but it's similar to that area. So to me, paradoxically, this funny ratio predicts the presence of small dense LDL better than triglycerides do, or HDL, which are correlated. The Australian cardiovascular risk calculator, which is derived from the New Zealand cardiovascular risk factor, we just copied there, they just did such a good job, that uses the total cholesterol HDL ratio. So no matter what they tried to do to get away from that ratio, that is the strongest predictor of cardiovascular disease. And guess what? It happens to be the most powerful predictor of small dense LDL. And this is from the 2022 review. They concluded that using ApoB and ApoA, using anything else, wasn't any better than total cholesterol HDL ratio. So they decided 2 years ago they're not moving from the total cholesterol HDL ratio, not because they understand anything about small dense LDL necessarily, but because it's just the most powerful predictor of cardiovascular outcomes. And now, you may not be able to read this, but this is different measures being ranked in their ability to predict cardiovascular disease. And the most powerful predictors down the bottom, and the top predictor is total cholesterol HDL ratio. The next most is the ApoB-A1 ratio. Triglycerides is towards the top. So now I just wanted to mention something. This is the correlation between total cholesterol and LDL. So R squared of 0.87 means there's a high correlation. If you measure a total cholesterol, it's pretty much your LDL. There's no real difference between total cholesterol and LDL. Most of your total cholesterol is LDL. If you've got a high total cholesterol, what is it most likely to be due to? A high LDL. So those two things are largely equivalent. This is the relationship between HDL and triglycerides. And this is, to me, a law of nature. the higher your triglycerides are. Now, this is actually the reciprocal of HDL. Remember, in this ratio, total cholesterol HDL, we're not using HDL, we're using 1 divided by HDL, if you like, the reciprocal of HDL. And the reciprocal of HDL correlates logarithmically with triglyceride. It's a law of nature. It's R squared about 8.9 as well. And it's actually a way that I use to check our results. If a doctor rings me up and says, oh, this triglyceride is wrong, it's too high, can't be right, I just look at the HDL. Well, the HDL's lower. What more proof do you need? So high triglyceride equals a low HDL or a high reciprocal of HDL. And it's a very reliable parameter. And what I've said in my other talks is that triglycerides vary a lot. Now, people on low carb says, no, they don't. My low carb don't vary much. You know, they might be 0.6 or 0.9. That's a lot. That's a 50% difference. If your total cholesterol went from 6 to 9, you'd say that's a lot. Well, 0.6 to 0.9 is also a lot. So triglycerides are highly variable, whereas HDL is not. HDL varies by about 5 or 10% from day to day. And so my summary there is that HDL is a better measure of triglycerides than triglycerides. That's why it works so well. That's why we can't escape it. And it's one of the reasons why I still prefer total cholesterol, HDL ratio versus trigs over HDL, because the top line on trig HDL is so variable. Now, which is the better marker? Now, I've been a bit flippant in a way by saying the total cholesterol HDL ratio marker is the better. It depends who you are. Are you a man or are you a woman? Have you got diabetes or not? It depends on who you are, which ratio works best. But in general terms, the total cholesterol HDL ratio works best in everyone. But in certain subgroups, like in non-diabetic women, triglycerides are the better predictor of cardiovascular risk. And you need to be careful in studies where they say this ratio is better than the other. On who? It's different. But for me, the total cholesterol HDL ratio is consistent in all groups, and that's why it's stuck in the cardiovascular prediction calculator, and that's why it's probably this relationship with small dense LDL. Now, the last thing I'll mention is this keto trial. So what Dave Feldman and his group did was looked for 2 groups of people that are low carb, lean mass hyperresponders, and a matched group. And the definition of the match was an LDL level above 190, which is above 5. An LDL level above 5, not a cholesterol level above 5. An LDL level above 5 equates to roughly a total cholesterol level of about 7.5 or 8. So these patients had to have an LDL above 5, a HDL above 1.6. That's a really good HDL level. A triglyceride level less than 0.9. How many of them do you think have got small dense LDL? None. I didn't really need to read anything else about this paper in terms of whether they're going to find any calcium scores or anything, because the total cholesterol HDL ratios are all low. And if you look at I've converted these values here. So the keto group had a total cholesterol of 9.5. The Miami Heart group was 5.3. But if you look back over there to the total cholesterol HDL ratio, which should be under 4.5, the lean mass hyperresponders had a total cholesterol HDL ratio of 4.1, which is pretty well below 4.5. It's good. And the Miami group had a level which is even lower. So it's been good to show that there's no cardiovascular risk in lean mass hyperresponders, but they weren't never going to show a difference between the Miami Heart group in terms of risk, because both groups were really low risk if you looked at the figures. And this was the issue about, their LDL cholesterol was much higher, but their, cardiovascular findings in the heart were equivalent. And there was no trace of any increase in plaque score with increasing LDL, which was very reassuring. It was great information for us as a community to have, that there's not this rapid acceleration of cardiovascular risk, which we suspected, but now we've got the proof for it. Just some other studies of Dave Feldman, which are interesting. This issue about how metabolism changes the cholesterol levels, the whole issue about VLDL being your fat transport system for energy, and you can manipulate that. And in this study, he manipulated in a way by underfeeding and then overfeeding in order to drop LDL. This was the hack. There was the cholesterol hack to get your life insurance. And the other thing that he did, his colleague did, was this Oreo cookie treatment. and he gave that to lean mass hyperresponders, and it was a very good way for them to suddenly drop that high LDL cholesterol. So for a lean mass hyperresponder who's worried that the GP is going to be really worried and put them on a statin, well, they just need a few Oreo cookies for a day and they'll be right. But it really proves the point of how much they reflect metabolism, and they're really promoting this lipid energy hypothesis. Lipids are about energy. They're not about atheroma in nature as much as they are about energy. And this relationship between the lean mass hyperresponder being the opposite of, with high HDL, very low trigs, high LDL, being the opposite of the atherogenic profile, which is literally the opposite: high trigs, low HDL, and high LDL. So in summary, we've got this black and white. We're so focused on pathology on the left-hand side: fructose equals fatty liver equals insulin resistance, fatty liver equals VLDL and high trigs in the blood. High VLDL means low LDL. High trigs means low HDL. High cholesterol HDL ratio predicts small dense LDL. Small dense LDL predicts atherosclerosis. That's all the disease sides. If you look on the health side, low carb means fat adaptation. Fat adaptation means that you make LDL because you're focused on fat for energy, but you burn it quickly. So the VLDL is low because it never really stays in the blood long enough to have high triglycerides. And then a low LDL means that you've got all this traffic of LDL being converted to LDL. So all the empty trucks, because your body's using up all that fat for energy, the empty trucks are lining up in your blood to get back to the liver and load up again. And so the high LDL is just a measure of this lipid energy traffic. And then the low trigs through CETP means you're not using up your HDL. Your HDL is a high normal level. And your low total cholesterol HDL ratio tells you that your LDL is in the large buoyant form. It's its normal transport form. And large buoyant LDL is the healthy form.
Thank you, Ken. That was a great talk. I'm a bit of a fanboy, so I really do need to thank you personally you've been a huge influence on my journey in low carb and lipids and so on and so forth. I'll just be quick with hopefully a couple of questions. HDL, do you have any visibility about modification of HDL representing pathology similar to the way we see modified LDL?
No, we don't have any glycated HDL measure, which would be of interest. The lipid profile that we have does have, different zones for HDL, but to be honest, I've never looked at it. I suspect it's just going to reflect what's happening to LDL, but I've never looked at it because it's never really been a question. But we do have some data sitting in the laboratory, and I'd be happy to review it with you if you're interested.
I'd be delighted.
Yeah.
I guess the point is I often observe elevated HDLs where anytime they get over about 2.8, it does seem to be suboptimal, in the same way that when I see triglycerides get 0.3 and maybe even 0.4, sometimes I see that representative of malabsorption and also possibly suboptimal. So I think the point is that I seem to be feeling that there's a centre point there where optimal levels are and the extremes are where the problem lay.
Yeah. Now, people have shown there's a J-curve for HDL, so very low levels harmful, very high levels also becoming harmful. They've been assigning most of that risk to genetics at the high end. There are some people that genetically have high HDL, which means there's something different about their lipid transport, and that may or may not be good.
Now, I'll just one more comment because I just want to keep the mic away from Grant because he looks really, really eager to speak. So, somebody asked me yesterday about glycation from fructose. We know that fructose has a glycation potential of 7 to 10 times greater than glucose. And the question was, how do we test it in pathology? And I was like, I don't know. I know that it might be reflected slightly in HbA1c, but it's certainly the dominant influence on HbA1c is glucose. Is there any tests we have for fructose glycation, especially considering, and I think this is just an important point, that people, when they have diabetes and they have higher blood sugar levels, there's a pathway that converts glucose to fructose. It's called the polyol pathway, and that can convert up to about 30% of glucose to fructose.
That's a great question, as I would expect. The fructose levels in the blood are like 1,000 times lower than glucose levels. The body does not want high fructose levels in the blood. They're micromolar level. But they do attach, as you say, it does attach. And when we're measuring hemoglobin A1c, we're focused on the A1c measure, which is glucose stuck to hemoglobin. But hemoglobin A1a and A1b are other adducts. And I'm pretty sure hemoglobin A1b is the fructose 1,6-phosphate adduct of hemoglobin. So we can get a measure in those labs running electrophoresis that capable of separating hemoglobin A1b. That would be a measure of persistent elevations of fructose. But yeah, it seems like the body does not want fructose in the circulation. And that's why it quickly converts it to fat in the liver and doesn't really let it out.